Hi everyone, welcome to another episode of Med Students Notebook, and today we are going to be taking the topic diseases of the pericardium. Okay, so this is our outline, introduction, anatomy and physiology of the normal pericardium, classification of pericardial diseases and types, etiology, clinical manifestation, lab investigations, and treatment. Remember, in every pathological cases, there is usually a more distinct outline. We have the history, the physical examination, investigations, and treatment. So if they ever tell you, oh, you should write a short note on a pathology, just make sure that everything you do is under this 4 distinct outline. And if you now want to write a full essay on how to about, like, this is the distinct outline for management of any pathology, right? But if you're now to explain a whole outline, write a whole essay, you can now start dividing it. At least this history would move into the introduction aspect, the anatomy and physiology, classification, etiology, and clinical manifestations. And these clinical manifestations also applies in physical examination, and then the lab investigations and treatment, as we can already see here. Okay, so now let's get into the pericardium properly. So let's imagine we have an onions and we are wrapping it up with a nylon. Okay, if you wrap up an onions with a nylon the first time, it's not going to be strong enough until you take it again the second time. I don't know, just have a visual imagination of it. To take an onions, right? Maybe you don't want it to spoil quickly. The onions is so delicate, and then you take up a white transparent nylon and then you wrap it up the first time, like a white film, let's just say a film. Okay, so you turn it, like you take the film around the onions the first time, then take the film round it again the second time, right? So that is how the pericardium wraps itself around the heart. Okay, so that part of the nylon that is directly touching the onions, okay, is what we now call the visceral pericardium. That is, look at it here, the inner layer of serous pericardium. All right, so let's call that nylon the serous pericardium. So the inner layer of that serous pericardium is the viscera, while the second wrap, that is the one that is wrapping it the second time, is now the parietal pericardium. That is the outer layer of the serous pericardium. Now, in between the visceral and the parietal, that is in between the outer and the inner layer, that is in between the first wrap and the second wrap, of course, there should be a space there. In fact, if you should take an injection and inject water into that space between the first wrap and the second wrap, you know that the water can stay in between those two. So is that space now that we are going to call what? The pericardial cavity, which contains fluid, and the fluid it usually contains is within 15 to 50 ml, and is usually like a lymph-like fluid. All right, so take note, that is just the simple meaning of pericardium. And then we now have another type of pericardium, like another layer. This is the fibrous pericardium, and the main work of this fibrous pericardium is what? Attachment. Fibrous. Okay, so it's not like it's wrapping per se, it's just another layer that just helps to attach the pericardium to surrounding structures in the thorax. So let's go over this. Okay, so the visceral pericardium is attached to the epicardial fat on the outer wall of the heart and reflects back on itself to form the parietal. All right, so let's say that onions, the purple thing that covers the onions. So I'm just going to draw an onions here. So this is the onions, right? Okay, so the purple back of the onion, so let's just call it the pericardial fat. That is the onion wrap, but let's just call it the pericardial fat. So that purple thing is the pericardial fat. Okay, and then let's represent nylon with let's say a light blue color. So you wrap the blue color film nylon around it the first time, so we just covered the viscera. Then you continue again with another extra layer of the nylon and wrap it around again. So this is the parietal. So in between the viscera and the parietal is now where we have our lymph-like fluid. That is the pericardial cavity. So this place is literally the pericardial cavity. I have to take my time to explain this so that you understand. This space that has this yellow fluid is the pericardial cavity. Okay, So the visceral pericardium is attached to the epicardial fat. That is the fat on the surface of the heart. Okay, so let's go. Between the layers of the serous pericardium is the pericardial cavity, and it has a normally filled, and it is normally filled by a lymph-like fluid, and we already said the quantity 15 to 50 ml. So normal function of the pericardium, first of all, it maintains an optimal cardiac shape. All right, so if I'm just going to explain these functions and I'll read through them as it is written on this outline. So let's imagine that onion that is wrapped with a nylon, right? If let's say normally an onion expands after 2 days, it will start expanding, becoming larger, So if we wrap it like that, in fact, the more the wrap safe around the onions, the more the restriction. So let's just say we wrap it 2 times strong, right? The onions cannot easily expand as much as it would. And let's now say you pour water on the onions from a running tap. The water is not going to touch the onions. It's going to touch the nylon instead. Maybe unless if you now leave the whole nylon and onions inside a full bucket of water, then maybe with time it can soak up water and become softer. But just pouring it under a running water, it will not soak up the nylon, right? And also, okay, so now let's get into it. So maintain an optimal cardiac shape, exactly what I said. The heart cannot be so, enlarged, because the nylon is already like covering it and keeping it in its shape. It's going to reduce friction between the beating heart and adjacent structures. Yes, because the nylon is soft. The pericardium appears to be like a soft pleural space. Okay, so it's a soft covering. So it's going to reduce friction. If the bare heart, if you're rubbing onions on the floor, you're going to hear very, 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 friction-like sounds. But I mean, if you now wrap the onions with a nylon and you're rubbing it on the floor, it's going to roll freely like a ball. You understand? Without making such sounds, right? So another thing it does is that it protects the heart from disease. Exactly what I said with water. If there is something like inflammation, TB, cancer, you're not expecting the onions to get affected immediately. No, you're not expecting that to happen. Why? Because it's not prolonged. Maybe in chronic conditions of TB and cancer, yes, the heart can get affected, but the pericardium itself prevents acute inflammation, acute infection to just get straight into the heart, unless if there are situations where there is no pericardium at all. Okay. Also, another thing it does, before I forget, is preventing overfilling of the heart. So that pericardium, it maintains cardiac shape. So even if blood, maybe through venous return, entering into the heart through the right atrium, then the right ventricle, if the blood is trying to be too much and overfill the heart, at least the pericardium has the right to even tell the no, this is enough, this is more than I can carry. It just keeps the heart in shape. So there are 3 physiological functions of the pericardium. I've already mentioned it, but let's now get into it in details. The first one is mechanical function. Okay. Second one, membranous function, and then third one, ligamentous function, and that is the fibrous pericardium. That is where it comes in, where we said that it fixes the heart anatomically in place. Okay. So back to the mechanical function. What it means is that thing I said about it, making the heart not to over expand. That is one. Another thing it does is that it's if the heart cannot over expand, that is overfill or over dilate, because the pericardium is limiting the movement, limiting the expansion, right? You're going to obviously expect Starling curve to be maintained and preserved. Okay, let's use the word they use. It's going to be preserved, because what does Starling curve state? Starling curve states that there is the preload is proportional. Preload, I'm going to denote preload with P, is proportional to cardiac output. So the more the preload, the more the cardiac output. So it's going to maintain cardiac output, because the preload is not going to be like 2xs, because the pericardium is, like we said, limiting the overfilling of the heart. Okay. Another thing it does is that it creates a closed chamber with subatmospheric pressure that aids atrial filling and lowers transmural cardiac pressure. The same thing we are saying, atrial filling is also regulated, and because of that, transmural cardiac pressure is maintained. The second function is membranous function. We said it's shielding the heart. Okay, like the preventing external barrier against infection, malignancy, and then friction. So that is the work of the membrane. So when you are thinking of membranous function, just think of things that now happen outside the heart, like the infection, malignancy, friction. Then if you're now thinking of the mechanical function, think of things that are coming into the heart. So obviously you're talking about filling of the heart, so you're talking about dilatation of the heart, ventricular compliance, Starling curve, atrial filling, and all of that. And then ligamentous function, I already said that fixes the heart anatomically. So now, pericardial lesions, right? We have different types of pericardial lesions. It can either be isolated, which is unusual because most pericardial lesions, pericardial diseases, right, are usually secondary to something. So, but sometimes they can be isolated. So, even though there is a large number of etiologies of pericardial disease, there are relatively few anatomic forms. All right, you can have a large number of etiologies, but there are relatively few anatomic forms of pericardial involvement. All right, so now let's start with congenital, because you can have, this page comes first. You can have congenital defects, then pericarditis, and under pericarditis, meaning inflammation, now we can have acute pericardial effusion, constrictive pericarditis, and then we can have pericardial neoplasm and pericardial cyst. So these are the 4 classifications that we are going to be addressing in this chapter. So for the congenital now, right, it's usually like, sorry that this is covering, but it's either left, comprises the left 70% or right 17%, or it can be both of them, so total bilateral. All right, so in most autopsies, like 1 in 10,000 autopsies, that is what is written here. It can either be partial left, right, or total bilateral. So we can also have absence of pericardium, but it is extremely rare, only seen in 30% of patients. But most patients that have total absence are usually asymptomatic. They will not even present with anything. So normally now, there is about, we said earlier 15 to 50 ml, but on a normal basis, like there's about 30 to 50 ml of thin, clear, straw-colored, I denoted straw-colored with yellow, straw-colored translucent fluid in the pericardial space, right? Now, if drainage wants to occur, it will first of all go to the thoracic duct, then the right lymphatic duct, and then into the right pleural space. Remember, pleural is for the lungs. Now, under a variety of disease conditions, you can now see pericardial effusions, but they hardly and rarely exceed 500 ml. But when there is a large volume or rapid accumulation of lesser volume, you will now see diastolic filling being, an issue. For example, now, let's say this is pericardial effusion, all this place. So this is obviously going to be the serous pericardium. Sorry, this is going to be the, I said serous. This is probably most likely going to be the visceral pericardium, just lining here. So this is most likely going to be the visceral, and then this outside one is most likely going to be the parietal. All right, so this is the parietal, this is the visceral, and then this is the fluid that is accumulated, now making this place to dilate. Now, if this place is dilated, you can see that left ventricles are usually larger. Left ventricle is supposed to reach here safe. Okay, let me use a different arrow to denote it so that I don't confuse. Left ventricle is supposed to be reaching here, because left ventricle normally is supposed to be bigger than the right ventricle. Okay, so if the left ventricle is reaching like this, and then the right ventricle is here, you are seeing that the should I say the it's as if the pericardial effusion is restricting the expansion of the left ventricle. I don't know if you guys understand that, but the pericardial effusion has reduced the size of left ventricle. I know it's the left ventricle that pumps blood to all parts of the heart. Okay, it's left ventricle that pumps blood to all parts of the heart, through the aorta. So if the pericardial effusion is constricting this end, and then blood is coming in from the left atrium to the left ventricle, it's not going to make the left ventricle fill up fast, because if you have a big cup and a small cup, right, or if you have a big cup and you used to fill it with 1 bottle of Eva water, and then maybe for some reason the cup shrinks and maybe it burns or something, but the cup shall reduces in size, that one bottle of Eva water really still fill it up? No, it's just like maybe half of the bottle that will now be filling up the cup. So that means the number of blood, the amount of blood that used to enter the left ventricle normally will not be entering it again, because the size has reduced, because the pericardial effusion is pushing it together. So let's move on. So what are the common causes? It can either be idiopathic, no known cause. It can be infection from outside. It can be autoimmune like SLE, rheumatoid arthritis, and scleroderma. It can be Dressler's or post-pericardotomy syndrome. So you're going to see Dressler syndrome later on. It can be neoplasms like lymphoma, lung or breast metastasis, because lung and breast is around the heart. It can be drug-induced like procainamide, hydralazine, phenytoin. It can be uremia or myxedema. Okay? Myxedema is like when there is like accumulation of fluid under the tissue, the subcutaneous tissue in the skin. Yeah, please just check that out, but that is what it is. So it's now give it a waxy, like it will give the skin a waxy feel. So pericardial effusion, we can have serous effusion, right? Okay, now we are now in pericardial effusion. Remember we told you that we can classify pericardial diseases or pericardial lesions into different things. We can have congenital defect pericarditis, another pericarditis, see pericardial effusion there. Then you can have pericardial neoplasm and pericardial cyst. So let's start with pericardial effusion. So for pericardial effusion, right, we have actually already talked about it anyways. So, or before that, let me just say, because I think I did not say it, I just continued it. I did not really say it as a topic on its own, as a subtopic on its own. So normally we have like 30 to 50 ml of thin clear straw-colored translucent fluid in the pericardial space. So normally they used to like drain through the thoracic duct and right lymphatic duct, then into the right pleural space. But when it's now over accumulates, it will lead to pericardial effusions, and these are the causes that we have gone through. And now when it comes to serous effusion now, which is a type of pericardial effusion, you see that the fluid is completely clear or straw-colored and sterile. When do you see things like this in cardiac failure? Because in cardiac failure, there's no infection, there's nothing. It's just an issue of, the blood, the heart's not meeting the metabolic, demands of the body, and then the blood is not, just things relating with blood, right? So the fluid that will be coming out from it in cardiac failure is just the serous fluid. It's just clear, straw colored, like there's no infection, no dots, nothing. And the serosal surfaces remain smooth, right? These surfaces, the serosa in between these lines, they remain smooth because there is no wahala, right, with the body in general. It's just that the heart is not, is failing. Let's just put it that way. Now, serosanguinous is in blunt chest trauma. And why? Because serosanguinous is like you see blood and you see serum. And when do you see blood? When there is like a blunt chest trauma, maybe accident or someone chokes knife and then you just puncture something, and then it's just both blood and fluid and everything. So in blunt chest trauma, and then you now see chylous. The word chyle is seen in lipid droplets, like during metabolism, right, in the stomach, lipids. So you see that one in lymphatic obstruction because the lymph nodes, the lymphatic drainage drains out excess fluid and lipids and blah blah blah, right? So chylous effusions, you see it when there's like a lymphatic obstruction and you now see it like draining into that pericardial space. Okay. And then we can also see hemopericardium, which is only blood. I don't know if you guys understand. So serous effusion is clear straw-colored fluid. Serosanguinous is in blunt chest trauma, so both blood and serum. And then chylous effusions, lymphatic obstruction, then you now see hemopericardium, only pure blood in the pericardial sac. Look at it here. All right. And it's different from hemorrhagic pericarditis, because hemorrhagic pericarditis is when there's like inflammation. So there's both blood and pus. Okay. That's the difference. So hemopericardium, only blood. Hemorrhagic pericarditis, blood and pus. Take notes. And then we can also have hemopericardium due to rupture of the heart wall. It can be seen in myocardial infarction or traumatic perforation or rupture of intrapericardial aorta. When the aorta ruptures, the blood will not be entering back into that pericardial space. Just look at it in this image. The blood, back again, let's continue. Blood rapidly now fills the sac under greatly increased pressure, producing cardiac tamponade. Now, cardiac tamponade is when let's use this image. So let's say this is the left ventricle here. This blood, obviously, is going to be pushing this heart. All right. So when there is a compression, that's the word we are going to use. When there's a compression, compression, right, of the heart. That is when you see cardiac tamponade. So there is cardiac tamponade. And then if they are doing CPR, you have to be careful, because CPR can cause like small trauma, and blood will not be in the pericardial space. So small amounts of blood results from trauma sustained during CPR. So you have to be careful doing CPR, because you can also lead to hemopericardium. You can be doing that, you want to save someone's life, and the person now have hemopericardium. Now, clinical manifestations of pericardial effusion, not pericarditis. Remember, I've seen in pericardial effusions so much fluid or blood in that pericardial space. So the symptoms, the one the patient will present, remember, symptoms is the one the patient comes to you with. Signs is the one you notice as the doctor. So for the symptoms, we can have dyspnea, difficulty in breathing, and then pressure symptoms, because that blood or fluid or whatever that is in that pericardial space is not only compressing the heart, it's also compressing surrounding structures. So if it's compressing the bronchus, you'll be expecting dry cough. If it's compressing the laryngeal nerve that controls speech, you'll be expecting hoarseness of voice. That is, the voice is deep. You understand? And then if it's not compressing the esophagus, you'll be expecting dysphagia. That is, person cannot swallow easily. Then for the signs, you can notice tachycardia, increase in heart rate, indistinct heart sound. You can also notice Elwart sign. That is when there's consolidation of lower lobe of left lung. By consolidation of lower lobe of left lung, we mean that you're going to be hearing like bronchial breath sounds, right? Because that left ventricle, because most times it affects the left ventricle. So that left ventricle is resting on that lower lobe of left lung. So of course, because of that, the lower lobe of left lung will now be consolidated. It will be stronger. So you, of course, are going to be hearing bronchial breath sounds. That is what you see in this Elwart sign. So let me just include it here. Bronchial breath sounds. So now, back to where we were. Hypotension. So we are going to obviously expect a reduced systolic blood pressure. Now, why is this? If the heart is not feeling very well, whether atrial filling or diastolic filling or whatever, because the left ventricle is more compressed, it's not pumping enough blood. So of course, you're not expecting enough blood to be flowing through the body. And because of that, there's reduced pulse pressure. And it can even be paradoxical pulse, because there's an exaggerated reduction of the pulse. Like, it's like, this pulse is too reduced, right? Especially greater than 10 millimeters, especially during inspiration. That's why I'm calling it paradoxical pulse pressure. There's congestion of systemic circulation, because I've seen distended jugular vein, edema. Why? Because if the heart is not feeling well, let's say this is the heart. This is the right atrium, left ventricle, left atrium, right ventricle. So now the heart is trying to feel. But because of there is like fluid compressing the heart, so everything is now smaller. The feeling that you used to feel, if you used to feel with like maybe, for example, 75 mils of blood, it cannot feel 75 mils of blood, because this left atrium or right atrium is smaller, right? So it's now be feeling, let's just say 50. So the remaining 25 will be flowing back, and it can cause edema. You get? So it's causing edema now is like a whole lot. Let's continue. We are now moving to pericarditis, which is inflammation. So itis, inflammation. And of course, once you hear inflammation, the 4 cardinal signs of inflammation is what? Pain, redness, swelling, right? Loss of function, and heat. So pain, of course, is the main characteristics of pericarditis. Pericardial friction rub is even very diagnostic of pericarditis. And then serial electrocardiographic changes is another thing that needs to be sure is pericarditis. It's usually secondary to a variety of cardiac diseases, systemic disorders, metastasis from neoplasms, so these are the things that can cause pericarditis. Remember, it's unlike pericardial effusion, right? This one, there has to be like it's not clear. The fluid is not clear. Like in the serious part of pericardial effusion. This one, there's usually something. So if there's no a disease, that means there's a systemic disorder. Or maybe there's metastasis. Remember, metastasis. It can be lung, it can be breast, it can be what? We saw 3 things. Lymphoma. From remote sites. Mostly from remote sites. Now, inflammations of the pericardium are usually secondary to variety of We have said that cardiac disease, system disorder, or metastasis. Now, primary pericarditis usually is unusual. Primary pericarditis is unusual. That is, the heart itself will just start becoming inflamed. It's unusual, but if it happens, it's usually viral origin. But now, most etiologies of pericarditis will evoke an acute one, while the ones like tuberculosis and fungi is chronic. Most things that will cause pericarditis, you just evoke an acute one just immediately. That is less than 6 weeks. But TB and fungi will produce the chronic one. There's also something called subacute. We'll see that later. So pericarditis is an inflammation of the pericardium characterized by chest pain, pericardial friction rub, and serial electrocardiographic changes. Now, for classification, it can be clinical or etiological criteria. So for clinical, it's based on like the time now. So we have acute, like we said, less than 6 weeks. So these are our thresholds: less than 6 weeks and greater than 6 months, and then in between. So less than 6 weeks are the acute, in between subacute, and greater than 6 months chronic. So 6 and 6. Ignore this 6 in the middle. I don't want to make it 6, 6, 6, but 6 and 6, right, are the time frames. Okay. So now, example of the acute one now. You see acute pericarditis in fibrinous, serous, or serosanguinous. Remember, serous is the clear one. Serosanguinous is the one that has to do with both blood and serum. Then for subacute, it can be effusive or constrictive. Then for chronic, it can be both constrictive, effusive, or adhesive. That is non-constrictive. Now, this is etiology. Remember, I said you are classifying it under clinical and then etiological criteria. That's what we mentioned there, clinical and etiological criteria. So back to our etiology now, since we are done with clinical. Clinical was to show the time frame. Now, for the etiology, you can have bacteria. You can have what? Fungi. We have already said, okay, we can have fungi, sarcoidosis, you can have TB, you can have rheumatic fever, we can even have HIV, and then we can have idiopathic. So back to our bacteria. We'll just go through the main points, okay? We can have direct extension and hematogenous spread, okay? So note that for bacteria, you can have both direct extension and hematogenous spread. And in 1 to 8% of the cases, it's bacteria that cause it. And it can also cause what? Purulent pericarditis. So for direct extension, maybe from the pulmonary or myocardial abscess, or penetrating injury from the chest wall from either trauma or surgery, to just inflame that pericardium. Or subdiaphragmatic, so you know the diaphragm is under the heart now. So subdiaphragmatic suppurative lesion, just direct extension. And to now start inflaming the pericardium. You start inflaming that nylon, wrapping the onions, if you have forgotten. The hematogenous spread, maybe from any other part of the body, is not even around. Because for this around, if you check, we have pulmonary, lung, myocardial, the muscle itself. Penetrating injury, maybe from outside, but straight into the chest wall. Either trauma or surgery. And then subdiaphragmatic, just the diaphragm. So as you can see, it's just around the heart. When hematogenous spread can be from anywhere, it can be bacteremia, maybe bacteria in the blood. It will spread from leg straight, or it can be sepsis, any part of the body. Pyemia, pus in the blood, it will just spread there. Now, for the organisms, you can have gram-positive like strep, staph, strep pneumonia, most especially, and other strep. And then for gram-negative, you can have Proteus, E. coli, Pseudomonas, Klebs, Salmonella, Shigella, Neisseria meningitidis, and Haemophilus influenza. The ELAs, Klebsiella, Salmonella, Shigella. Remember E. coli, of course, which is gram-negative, and then HI, Haemophilus influenza. Now, let's come on now, like the Legionella, Nocardia, blah, blah, blah. We can go through this later. Anaerobes has also been isolated, though. And also, in reviews of pediatric population, more anaerobes are there. So, TB, 4% of the cases. High-risk group are elderly patients in nursing homes. Elevated adenosine deaminase is useful for diagnosing TB. So, when there's high adenosine deaminase, poorer prognosis. Okay? And most of them develop constrictive pericarditis. So when do you see constrictive pericarditis in TB? Sarcoidosis. Pericarditis is present in autopsies in approximately 25% of these patients. But this one, it rarely causes cardiac temperament or constrictive one. Unlike TB, that causes constrictive one. TB will constrict the heart. Maybe for you to remember, I just know that TB has to do with the lungs. So maybe the lung, blah, 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 whatever will happen to the lungs, it will now start constricting it. But sarcoidosis, it hardly constricts. That's what differentiates it from TB. Okay, so imagine I tell you later, sarcoidosis versus TB. First thing that should come into your head is TB constrictive, sarcoidosis non-constrictive, rarely at least. And also, patients might not even have like significant MI, myocardial infarction. Now, rheumatological causes like rheumatic fever. Now, for the rheumatic one, it usually accompanies both endo and myo. Apart from pericarditis, it can also have endo, myo, and it has worse prognosis when it's both endo, myo, and peri, because endo is inside the heart, myo is the muscle gongon, and then peri is the outer. So if you rheumatic, in fact, very greedy go to encompass a lot of them. Now, in adults, pericarditis may not occur with myocardial or valvular involvement in adults. So it is usually associated with better prognosis. Alright? So in adults, better prognosis. So now if it's in rheumatic fever, because it is autoimmune, anti-streptolysin O titer is greater than 400. In rheumatic heart fever, just check ASO. If it's greater than 400, it's most likely suggesting rheumatic heart fever. Then rarely is a large effusion present. Large effusions rarely present. Now for etiology again, HIV. Pericardial involvement is frequent, but it's usually asymptomatic. But it usually is an asymptomatic pericardial effusion of small volume. Small volume. The same thing with this one. Rarely is large effusion present. So as you can see, both HIV and rheumatic rheumatic fever causes small fluid. So it is found frequently in people with advanced HIV infection. Of course, you can't see it in the early one now, you see it in the advanced one, right? So etiology can include like opportunistic infection, Kaposi sarcoma, HIV virus. Now other infectious agents can cause it, like the fungal, the histoplasma, blastomyces, aspergillus candida. Parasitic ones like toxoplasma, Entamoeba histolytica, echinococcus. It can also be idiopathic, like in 26 to 86% of cases. Clinical features will now differentiate this from that viral one. Remember I told you most of the ones that just happen in the hands, gone, that is not from outside, is usually viral. So, if you now check the clinical features, you can now know if it's viral or idiopathic. Most likely, the majority of idiopathic cases are undiagnosed viral ones. So there's now a war between is it idiopathic or is it viral. That is especially if it is coming from something you don't know in any other part of the body. You have checked HIV, it's not HIV. You have checked rheumatic, it's not rheumatic. ASA is less than 400. Way less than 400 safe. You have checked TB. There's no TB. You have checked sarcoidosis, it's not it. You have checked bacteria. You have checked if there's bacteremia, pyemia in any other part of the body, nothing. And because of that, you're like, if none of these things are causing it, I've checked blunt chest trauma. Is there any trauma? Any fall? Any accidents? Nothing. You're not like, okay, it's either idiopathic or viral. They now check and you're not seeing any viral thing. Now say, okay, maybe it's idiopathic. But now they're trying to tell us that most idiopathic cases are undiagnosed viral ones. I hope this makes sense. So other inflammatory conditions that can cause it, you can just go through it. Vasculitis, poliomyositis, Reiter syndrome, serum sickness. There are just so many. Now, renal failure. Funny enough, renal failure can also cause that pericarditis. Why? Because of uremia. When there's renal failure, it's not excreting as much urea. So, excreting urea, no. So, urea will not be so much. And when there's urea, it will enter the blood. And of course, it will enter the heart. And there's not too much urea in the heart, it will destroy those chambers. Okay, but now when there is dialysis, because some people do dialysis, so now in pre-dialysis era, pericarditis developed in 35 to 50% of patients with uremia who had chronic renal failure. So the chronic renal failure, they excrete urea now. So most of the time they just have pericarditis. Death will not follow in several weeks. But now when dialysis started happening, it started reducing to less than 10%. Okay, so uremic pericarditis is different from dialysis-associated one. Take notes. Asymptomatic pericardial effusions can occur in 36 to 62% of patients in uremia. So the main point is uremia can cause pericarditis, especially if there's no dialysis to remove it, and especially if it's in chronic renal diseases. chronic kidney diseases. The presence of large pericardial effusion that persists for longer than 10 days after intensive dialysis has, in fact, if there is pericardial effusion and it's still increasing, you should start expecting cardiac tamponade very soon, like compression of the heart. Dressler syndrome. So pericarditis associated with Dressler syndrome is observed 2 to 3 weeks after myocardial infarction. So Dressler syndrome is when there's like an autoimmune mediated phenomenon. It's autoimmune, okay, and it's like the immunity is fighting against myocardial antigens. Okay, so they can present with Dressler syndrome. Patients may develop pulmonary infiltrates and large pericardial effusions. Because of the risk of hemorrhagic pericarditis, anticoagulant therapy should be stopped. Imagine you're giving an anticoagulant when someone is bleeding. Very bad. Okay, so in Dressler syndrome, they have the chances of developing what? Hemorrhagic pericarditis. So don't give anticoagulant therapy. So we also have cholesterol pericarditis. This is also called gold paint. Cholesterol shines yellow, so let's just say gold paint pericarditis. Now, granulomatous pericarditis has been implicated in some cases. Development of constriction is rare. Okay, that means in cholesterol own constriction is rare. Like in which one too? In which one? Sarcoidosis. Which one is there constriction usually? Why? Which one is constriction usually present? TB, among others. Safe. Now, clinical manifestation of fibrous protein pericarditis. Remember, we talked about clinical manifestation of pericardial effusion. You have seen that it's so different from clinical manifestation of pericarditis. So one of the symptoms, chest pain. And now for the position, it's usually like behind the sternum, retrosternal. So if this is the sternum, it's just behind. So it's behind the sternum, retrosternal. Okay? Or pericardium or mid dissection. Now we also have character, sharp pain or dull pain or compression. You would see compression more in pericardial effusion, but sharp pain or dull pain, suspect pericarditis. And now, if that patient tells you, oh, the pain worsens when I breathe in deeply, or when I cough, or when I lie down on my back, suspect pericarditis. And if the patient even calls to add that it's when I sit down or lean forward, it will relieve, pericarditis, especially if it has both sharp pain and dull pain and it's behind this their sternum they are pointing. Pericardial effusion rub, remember I said it is diagnostic. Pericardial effusion rub is on auscultation. When you are listening, you are hearing like a squeaky sound. Okay, so we have gone through this one before. Signs, so you can, they're just putting it so we can compare. This is now the pericardial effusion. Remember I said difficult in breathing and then pressure symptoms, right? And they also talked about airway time because it's compressing the lung, hypotension because it's not releasing so much blood, so the blood pressure will be low paradoxically, and then SPP, that is systolic blood pressure, is lowered, and then you can also see edema, just things related to feeling. Then pericardial effusion rub, remember I said it's high pitched, leathery sound, it is squeaky. It's usually systolic but can be diastolic too. Sometimes they can have 3 components, say pericardial cycle, and it is best heard if the diaphragm is applied from to the what? Left lower sternal border. This is sternum here, so towards, most likely towards the what? Right part of that, because if this is the heart, this is the right atrium, left ventricle, so this is most likely the right ventricle area leading to the left ventricle. That's when you hear that pericardial friction rub sound. Variable in intensity and may be intermittent. Its absence does not exclude the diagnosis, but its presence should relate you more, should direct you more to pericarditis. Clinical manifestation, we have cardiac tamponade, pericardial effusion, like acute ones, Beck's trialogy, hypotension or shock. So the Beck's trialogy are the hypotension or shock. We are using HID, hypotension or shock, because like we said, blood is not flowing as it should. So of course there's reduced systolic blood pressure. Indistinct heart sound, like we said, you can be hearing some squeaky sounds, whatever, and then distended jugular vein. All right, so subacute or chronic, this is in the acute phase. This is what you'll be hearing in cardiac tamponade. But in the subacute or chronic phase, you now start seeing an increase in venous pressure, congestion of systemic circulation, cosmal sign, that is the jugular vein is now dilating during inspiration. Here it is distending, but now any inspiration it will dilate. And laboratory findings, this ECG. These are normal ECG, right? The PQRSTU. But now, what we are going to expect in pericarditis, in acute pericarditis, is that, first of all, the ST segment, widespread elevation, it will be longer. The ST segments also have an upward concavity. There is no significant Q wave changes, no Q wave pathology. Remember, in this thing, this is relating to the atrium, this P wave, atrial. Then from here to here is ventricular. So ventricular depolarization and ventricular repolarization. So from here to here has to do with ventricular relaxation and contraction and relaxation, basically. Contraction, relaxation. Atrial contraction. As you can see, there's really no atrial relaxation, because before an atrial relaxation occurs, ventricle is already contracting. So atrial contraction, ventricular contraction, and ventricular relaxation. Okay. So ST segments have an upward concavity. There's no significant Q wave changes. But after a few days, the ST segments return to normal. So at first, ST segment is concave upwards, and then after it returns to normal, it returns to being flat. Then after the ST segment returns to normal, the T wave will now become inverted. So this is the T wave that is up. It becomes inverted. So it becomes like this. Okay. So now this is it. Back again. These are acute pericarditis. Like we said, ST elevation, concave upwards, usually diffuse, no reciprocal change. Start ST elevation and then back to normal. Then T wave will now invert. No pathological Q wave, and may be PR segment depression, may. But in myocardial infarction, ST elevation, but it's convex what? Upwards. Why this one is concaving upward? This one is convexing upward. I hope I'm not missing. I think concave is like this, convex is like this. I'm now confused. But it's usually localized. Why this one is usually diffuse, the pericarditis. But this one is usually localized because myocardial infarction is at one point of the heart. There may be reciprocal changes, ST elevation, QT wave inversion may be together. So this is it. Now for laboratory findings. On chest x-ray, we are going to see clear long field. See, the long field is clear. Let me clean the image I drew. So you see that it's clear. So clear long field, okay? And the cardiac shadow will now show an enlarged water bottle sign. So this enlarged water bottle appearance, clear long field, and then cardiac shadows changes with posture. If you move like this, the cardiac shadow will change. Alright, so these are the laboratory findings. So this is it. Laboratory findings on pericardial effusion, right? This is another one. You can see. We have seen this image before. Echo is the best non-invasive investigation for confirming diagnosis of pericardial effusion. Echo is the best. You can see the myocardium, you can see the effusion, and you can see the pericardium. Inside there is the endocardium. So endocardium, myocardium, pericardium. See the effusion. The effusion is not supposed to be here. It's not even supposed to be this big, because normally the pericardial space has something there. It said 15 to 50 mils. But now it's too much. Now for laboratory findings, again, like this ECG, the best. Pericardiocentesis, you put a needle and bring out the fluid, so you check out the fluid. It can help to make diagnosis. Fluid should be sent for culture and assay. Protein, glucose, LDH assays, LDH glucose. It will determine, is the fluid exudative or transudative? Okay. An exudate would denote infection more because it has more protein, more than a transudate. Cytology or tumor marker: CEA, AFP, CA125, CEA, AFP. This one, I think, this is colon cancer. This one is alpha fetoprotein. This is CA125. Okay, so I think, is this breast or ovarian? This should be ovarian. ANA assay, if collagen vascular disease is suspected. Pericardiocentesis can relieve the pressure too. Like we said, they are putting in needle and bringing out that fluid to check it out and send it to for cytology and culture and assay. So even if you remove that fluid, it can even relieve the pressure, especially if there's congestion. So diagnosis of acute pericarditis: chest pain aggravated by coughing, like we said, inspiration, or recumbency, that is lying down on your back. Pericardial friction rub on auscultation. Characteristics: echo changes. Chest X-ray and echo may find what pericardial effusion. Now these are the differential diagnosis. So if the history comes with, there's respiratory tract infection, acute onset, and then there's fever, you should be thinking of what? Itis, inflammation. Okay, because there's an infection. Okay, and fever is constant, inflammation. And then pericarditis, if you now listen, it's obvious. And then chest pain is severe. Of course, you should be thinking of itis. Okay, if your classification of leukocytes, I see more lymphocytes suggesting an infection, and then bacteria, no bacteria. Treatment: NSAIDs. It should be, since there's no bacteria, that is why it becomes acute idiopathic. Because all these things, you're saying, okay, maybe there's a bacterial infection, but there's no bacteria. So you should be expecting what? Acute idiopathic one. Because only lymphocytes are elevated, showing white blood cells are fighting, but there's no bacteria. So you don't know the cause. But for tuberculosis, pericarditis is accompanied with TB, no fever. Pericardial friction rub, often. Chest pain, seldom, meaning hardly occurs. More lymphocytes. Tuberculous bacillus may be found. Anti-tuberculous bacillus is the treatment. And for this one, give NSAIDs. This one, anti-tuberculous. This is for tuberculous pericarditis. Then for purulent, accompanied with original infection, lesion, or septicemia, there's high fever. Often, all these things are pericarditis. So of course, we should be expecting pericardial friction rub. Chest pain, often. More neutrophil. Purulent bacteria. Then start suspecting purulent pericarditis. Then you now give antibiotic because it's what? Bacteria. Then for malignancy, maybe there's metastatic tumor, there's no fever or seldomly. Pericardial friction rub, no, because it's not a pericarditis. Chest pain, no, because it's not pericarditis. Malignancy, more lymphocytes. Bacteria, none. So for this one, just treat that original disease. Then pericardiocentesis, just to be relieving the fluid. Then post-pericardiostomy syndrome, issue of cardiac injury, maybe operation, myocardial infarction. Of course, you're not expecting fever or pericardial friction rub or chest pain because it's not pericarditis. But okay, you can expect fever because maybe there is a cardiac injury, right? Yeah, the fever is possible. So these are it. And then if it's for this one, just give steroids. Now, for treatment, you can have both medical or non-medical or surgical. You can give bed rest, NSAIDs, aspirin, indomethacin. Then for steroids, you can give prednisolone 40 to 60 milligram daily. Now for the treatment, for the etiology, if it's bacterial infection, okay, for treatment, check the etiology. Is it bacterial? Is it viral? Is it TB? Is it malignant? Is it collagen vascular? More like the things we listed up there. Then relieving pain and inflammation, give NSAIDs and steroids. If the symptoms are severe, pericardiocentesis is indicated to be removing the fluid first, especially in that malignancy aspect. Now for the treatment again, okay, I've gone through that. If symptoms are severe, pericardiocentesis is indicated. Why are they repeating things? Okay, it can be medical or surgical too. For constrictive pericarditis, pericardiectomy. If it is constrictive, just remove the pericardium. Just remove it. Let the heart be free. Understand? Remove that pericardium. I know you say, oh my God, you're not removing the nylon covering the onion. Sweet it. Yes, just remove it. Because it's now constrictive. It's now like it's now hard. In fact, the heart is too. In fact, it's pushing the heart too much. If the nylon is tightening the onion too much, you need to remove the nylon. Yes. Then bed rest, NSAIDs, the same thing. They're just repeating. Thank you. Any questions? We'll see you in our next video. Bye, guys.